Welcome to Nurse Tutor Videos NCLEX Video Review. This videotape is about pharmacology. I'm Judy Miller, and I'll be your guide for this tape. On this tape, we're going to talk about a number of things. We're first going to talk about some concepts related to drug administration. Then we're going to talk a little bit about administering IM and SubQ and IV, etc. Then we will be taking drugs by category. And as we take drugs by category, we'll be looking at commonalities and differences among those categories. First, let's start with the concepts of drug administration. Remember that when you administer a medication, you need to first always check the expiration date. You need to check the label at least 3 times when you're removing it from the drawer, before you prepare it, and after you prepare it. Make sure that you identify the client before you give any medication, and remember that the ID band is always the best form of identification. Never simply say to the client, "Are you Mr. Smith?" Because particularly with confused clients, they may say yes, and if you said, "Are you Mr. Jones?" they'd say yes. "Are you Mrs. Smith?" Yes. So that oftentimes with confused patients, they really will answer to almost anything. If you have to ask a patient his name, ask him what his name is. Remember that in long-term care facilities, you do have a photo ID on record. So if the client loses their identification band, go back to that photo ID. Remember also that you give the right dose of the right drug to the right client at the right time by the right route. And they could even ask you as simple a question as the fact that you need to wash your hands before you administer medications. They're really big on that type of thing. Remember, when you give the medication, that you want to stay with the patient while he takes the medication. You want to give it within 30 minutes of the prescribed time. You want to chart it immediately. You want to observe for reactions. And you want to teach the patient about the medication that he's receiving. That's a very important part of nursing care. Now let's take a moment and look at some of the routes by which we administer medications. And first we'll talk about intramuscular. You might have questions that relate to the size of the needle to be used, and you'll probably be using something between an 18 and a 23 gauge. Most of the time we're using 20, 21 gauge needle. Remember, when we talk about gauge needle, the bigger the number, the smaller the needle. So you'd really much rather have a shot from a 23 gauge needle than you would from an 18. The 23 gauge needle makes a smaller hole. The needle will be 1 to 2 inches long depending upon the size of the patient. Now what determines the needle of choice is going to be the medication to be administered and the size of the patient and the site of administration. So if you have a very thick, viscous medication, you're probably going to use a 21, 20 gauge needle, possibly a 19 gauge needle. If you have a very thin medication and it's a small patient, you might well use a 23 gauge needle. Remember that when you give an intramuscular injection, you hold the skin taut and inject at a 90-degree angle. Major sites include the gluteus, both minimus and medius, rectus femoris, deltoid. We can also use the vastus lateralis. If we think about how to measure those sites, if you take a look at the picture, you'll note some of the landmarks that we need to be aware of. We want to first avoid nerves and blood vessels in the area. So you may have learned to make a cross and or dissect the buttocks into quadrants and given the upper outer aspect of the upper outer quadrant, and that's fine. You also may have learned that you need to locate the greater trochanter and locate the posterior superior iliac spine. Draw an imaginary line between those two and then give in the upper outer aspect of that area. You're reaching the same spot no matter which way you use to find it. Just a word, while locating the landmarks is usually the preferred method, it's often very difficult in very large people. It becomes very hard to feel that greater trochanter if there are too many layers of padding on top of that. You might also recommend to patients that when they're laying there, they actually toe in, put their toes inward. That helps to relax the muscle and makes the medication hurt less. We want to also take a look at the next picture and note another good spot for us to give medications in the gluteus medius muscle. This is particularly helpful when a patient, you've just settled and positioned a patient and they need an injection. You don't want to have to turn them back over. So this can be done with a patient in a side-lying position. Again, we need to locate landmarks, the greater trochanter of the femur, and on the iliac crest, now we want to find the anterior superior aspect of the iliac spine, and then make actually a V with our fingers. And what you'll notice is that you have a nice spot in there of muscle that can be used. This is probably an underused site and certainly one that's very appropriate to use. We need to remember that we do not give IM injections in the gluteus to children. With children, we're probably going to use the vastus lateralis site. And the vastus lateralis is on the side of the thigh. You may want to locate the knee and locate up by the hip area, and in between there is where the vastus lateralis is. You cannot use a gluteal site until the child has been walking for several years. So this means that just because they started walking last week, they aren't ready yet for a vastus lateralis site. We can also use a deltoid site sometimes. And of course the deltoid is in the arm. Locate the shoulder and locate the elbow, and then in the upper part in between there is an appropriate site to give an IM medication. We want to talk about subcutaneous medications. Subcutaneous medicines, we use a smaller gauge needle, about 25 to 27 gauge needle, and it's shorter. It's ½ inch to 1 inch long. With a subcutaneous injection, you pinch the skin because we don't want to go so deep, and administer at about a 45-degree angle. Medications, there's only one type of sub-Q medication that we don't administer at the 45-degree angle, and that's occasionally with insulin. Insulin, we use such a very short needle that even though we're giving sub-Q, we often use a 90-degree angle unless the patient is extremely skinny, and then we might need to use the 45-degree angle. The sites for subcutaneous include the outer aspect of the upper arm, the anterior thigh, and the abdomen, being sure that we stay at least 1 inch away from the umbilicus. And another type of injections that are sometimes given are intradermal. This we use a 25 or even smaller gauge needle, usually 1 inch long or less. With an intradermal, we stretch the skin taut, and remember that we certainly do not want to massage an intradermal. This is used for things like skin tests. So your tuberculin skin test is intradermal. We actually, with the intradermal, raise this little wheal, W-H-E-A-L, or bleb, with that. The sites that we use are usually the ventral forearm for the test for like tuberculosis and histoplasmosis. We might use the scapula and upper chest area for allergy skin testing. We could also administer medications rectally, and when we use rectal medications, these are suppositories. Just a couple of words about those. Remember, you use gloves. You moisten the suppository with a water-soluble lubricant. Now that's the term they're going to use. They're not going to say KY jelly on the exam because they like not to use brand names. You insert the tapered end about 2 inches, making sure you're past that internal sphincter. And then be sure you pinch the buttocks, because as you go through the sphincter, the patient will have an urge to defecate. So be sure to pinch the buttocks and have the patient retain the medication. At least 10 to 20 minutes and longer depending on the medicine. If it's a suppository to cause bowel evacuation, 10 to 20 minutes may be sufficient. If it's a suppository with general medication like anti-nausea drugs, there's no hurry at all to expel it. Just at some time later, what's left can be expelled. Need to take a little look at some eye medications. Remember that you want the client supine with their head turned to the affected side. And they go in the conjunctival sac, and you put pressure on the inner canthus. That's right in here, the inner canthus. And that prevents the medication from entering into the tear duct and getting into the systemic circulation. Ear medications, you put the client on the unaffected side, clean off the outer ear, straighten the ear canal. Remember, it's up and back for adults, down and back for children. You get down to the child's level. And that's for small children. These would be for infants and toddlers. You instill the drops and have the client stay on their side for 5 or 10 minutes. You can put a little cotton, moistened with the medication, just into the ear, and that will help the medication stay in place. Now, don't put dry cotton in because that would wick the medication out. And we want to take a moment and look at some IV medications. When we talk about IV, we can give IV medications via a heparin lock, via a piggyback, or sometimes just straight drip. When we talk about a heparin lock, it gets its name from the fact that heparin has been used as an anti-clotting agent. Some people are now just simply skipping the heparin piece. But the procedure goes like this. The port is swabbed. It's then flushed with 2 cc's of saline. You administer the medication, flush with 2 more cc's of saline, and then flush with 10 to 100 units of heparin, depending upon your agency's protocol. Studies have shown that without the heparin, you can be just as effective as you are with the heparin. So many places are eliminating the cost of the heparin. This is ideal because this allows you to have venous access without the patient having to run around with an IV attached to their intercap. A piggyback solution is when we're giving a secondary solution to an already existing IV line. Now remember that the piggyback, the secondary solution, must be above the primary solution in order for it to drain in. If it's below that, gravity being what it is, the primary solution would take precedence. The one that's highest is going to run in first. Let's do a calculation question. The physician's order reads, infuse 600 units of heparin every hour. The pharmacy prepares a solution of 250 milliliters of D5W containing 12,000 units of heparin. This solution will infuse at how many milliliters per hour? And you have your choices of 12.5, 30, 50, or 100. Now take a moment, you may want to turn off the tape and do your calculation. Hopefully you have come up with the number 12.5 milliliters per hour. You might want to take a look at 2 different ways to calculate this. My method that I really prefer is where we're doing the is-to, as-to approach. 12,000 units is in 250 milliliters. So 12,000 is to 250, as 600 is to an unknown quantity. We don't know how many milliliters contain 600 units. And remember that when you set it up this way, if you have units to milliliters on one side, you have units to milliliters on the other side. Moving that down, it comes to 12,000x equals 250 times 600. And then if we divide, we get x equals 150,000 over 12,000. Get rid of those zeros. And finish your calculation. X is 150 over 12. And when you do that, that comes out to 12.5. You can see the other method as well on the overhead. That was so much fun. I think you should do another one. The physician's order reads, add 200 units of regular humulin insulin to 1,000 milliliters of 0.9% saline solution. to infuse at the rate of 3.6 units per hour. If the drop factor is 60 microdrops equal 1 milliliter, how many milliliters of this hormone infuse per hour? Now, the first thing of a question like this is to sort out what data you need and what you know, what you don't. The 0.9% solution is irrelevant. That's a number that's just put in there to make the question accurate. Essentially, what we have is 200 units in 1,000 milliliters, as 3.6 units is to X. So once again, we'll use my favorite method first. 200 units is to 1,000, as 3.6 units is to X milliliters. Solving that out, we get 200X equals 1,000 times 3.6. X equals 18 milliliters. We could solve it in the other method as well, which is on your screen. And we're going to do just one more mathematics problem. A 60 kilogram adult is to receive Hyzid 5 milligrams per kilogram PO divided into 3 doses. If each tablet contains 50 milligrams, how many tablets would you administer per dose? There are obviously several steps that we have to take in solving this problem. This one is a bit easier than some in that we're already given how many kilograms the adult weighs. Sometimes you may have a problem that says the person weighs so many pounds. In that case, the first thing you have to do is convert pounds to kilograms. And remember that 2.2 pounds equal 1 kilogram. But we already know he's 60 kilogram adult, and he's to get 5 milligrams per kilogram. So multiply 60 times 5. That solves your problem in terms of 300 milligrams is the total amount that needs to be given. But it's to be given in 3 doses. So that would be 100 milligrams per dose, and each tablet contains 50 milligrams. We could do our desired over half. 100 over 50 is 2 tablets. Now, you may find on NCLEX that you have questions where you have to do several steps. The most important thing is to be sure you're dealing with like units, for instance, kilograms and kilograms, milligrams and milligrams, and then go ahead and proceed to solve the problem. Do it step by step. The math part will not be difficult. What's difficult is just deciding on the number of steps to go through. Now, as we start to talk about the drugs and try to make some sense of the hundreds of thousands of drugs that are available for us, I think we first need to get a few concepts about drugs themselves. If we think about the metabolism of oral drugs go first to the liver, then to the systemic circulation. So everything that's picked up from the mouth, from the GI tract, goes to the liver, then to the systemic circulation. This means that you often have to have higher doses of oral drugs than you do parenteral drugs, because they're going to be broken down in the liver before they get into the bloodstream. Parenteral drugs, on the other hand, get first into the systemic circulation and then to the liver. So that's an important difference between those two. Now, parenteral, remember, is anything other than oral. So it's IV, IM, sub-Q, etc. A word about metabolism of drugs. We said that usually the dosage of parenteral drugs is less than that of oral drugs. Parenteral drugs act more quickly because they can bypass the liver, essentially. Liver disease will affect the metabolism of drugs. Most drugs are broken down in the liver, and most drugs have the potential for liver toxicity. That's a nice thing to remember when you're trying to figure out toxicity to a particular drug. Most drugs are excreted via the kidney, and so we have to keep an eye on kidney function with most drugs. Some drugs are more nephrotoxic than others, but that's an important concept for us to keep in mind. Now, if you really want to master pharmacology, we need to remember that drugs in the same classification usually have similar actions and side effects, so that once we can learn the actions and side effects for a class of drugs, then we can find out the slight differences with drugs in those categories. But usually you'll be far better off putting a drug in its class and learning about the class rather than trying to learn about each drug individually. Now, as we begin to start the specific classes of drugs, the first major group that we're going to start with are antimicrobials. And this is one you want to pay particular attention to, because unlike some of the other drugs that pop up as you're discussing various body systems, these apply across so many areas that sometimes these are drugs that you may not have learned as well as, say, heart drugs. Antimicrobials, there's a few general rules. We want to culture before we give the antimicrobials. These are given obviously for infections, so if we want to find out what the specific infection is, the culture comes first. Give at regular intervals. It's important that we keep the therapeutic levels high enough, so we need to give these at regular intervals. The drugs, unfortunately, kill bacteria, viruses, microbes in given categories, so that quite often what we see is that they may not only kill the invading drug, the disease-causing bacteria, but they may also kill other bacteria, so that we can get superimposed infections when people are taking antimicrobials. And you must be sure to teach the client to take all of the medication. The tendency is, when the infection seems to be clearing, that the patient may decide, I've had enough. But we must teach them to take all of the medication. Many antibiotics also interfere with oral contraceptives. Many can cause liver or renal damage in high doses. And most of them can cause blood dyscrasias when they're given in high doses or for long periods of time. Now let's start looking at the specific categories. We want to talk about aminoglycosides. These essentially are the mycins except for erythromycin. So these are streptomycin, gentamicin, kanamycin, etc. But essentially the mycins except for erythromycin. These are given IV or IM if the client has a systemic infection. They're only given orally to treat for bowel disinfection, because they are not systemically absorbed. They're not absorbed from the GI tract when you give them by mouth. So if you want to clean out the gut, get rid of the bacteria in the gut, then you give neomycin or kanamycin by mouth. If you want to treat a systemic infection, you must give streptomycin, gentamicin, for instance, IV or IM. Now, this is a category of drugs where you absolutely positively have to know the adverse effects. And the two biggie ones are eighth cranial nerve damage and nephrotoxicity. Now, eighth cranial nerve, as you remember, is the auditory nerve. So these patients have hearing loss, tinnitus, ringing in the ears. They have balance problems. The nephrotoxicity, to pick that up, you need to monitor BUNs and very specifically creatinine levels. You might want to keep an eye on intake and output as well. Occasionally, patients with aminoglycosides can get neuromuscular blockade, although this is certainly less common than eighth cranial nerve and nephrotoxicity. You might just note the pictures and note that the outer ear and the kidney are roughly the same shape. That might be a good memory tool for you in terms of remembering those side effects. And there's one more thing that's really important for us to know about aminoglycosides, and that's the peaks and troughs. When we talk about peaks and troughs, you need to draw the peak level if this is being given IM an hour after the injection, if it's IV 30 minutes after the administration. And we want to find out what the medication level is at peak. And then the trough we do just before you give the next dose. Peaks above 12 micrograms per milliliter and troughs above 2 micrograms per milliliter are associated with higher toxicity. And this is very important for us to monitor. Let's move and talk about another drug in that same general family called vancomycin. Vancomycin is technically unrelated to any other drug. However, vancomycin has the same side effects, the same cautions that we have with the aminoglycosides, and it sounds like aminoglycosides, so for all practical purposes, it's the same thing. As we move into the penicillins, one of the biggest families of antimicrobial agents and one of the oldest families. It can be used for all kinds of things, for gram-negative, gram-positive. It's used in things like syphilis, to kill the Treponema pallidum, meningitis, pneumonia, streptococcus. It's used for a whole host of problems. Note that all the drugs in the penicillin family are going to have the "cillin" suffix to it. So you have penicillin and amoxicillin and methicillin and oxacillin and piperacillin. They all have "cillins" in their name. When some of the biggest concerns that we have with the penicillins in terms of side effects, in addition to those general ones that we saw for antibiotics, are allergic reactions and anaphylactic responses. So you must always ask the patient if they have any allergic reactions to penicillin in the past. Now, a negative response does not mean that we're not concerned about it, because patients usually do not get an allergic reaction the first time you give the drug. The allergic reaction usually comes on a second or 10th or 20th or 50th time you've given the drug. The first time sets them up for it, and after that is when they're more likely to get it. If the client tells you they've had an allergic reaction, first find out what type of reaction was it. If it was a simple rash, you certainly report it, but the physician may risk giving it to the patient, because most of the time when they simply get a rash, it's more apt to have been the underlying disease causing the problem than the penicillin. However, if they report hives, if they report asthmatic type, anaphylactic type reactions, then you certainly would want to be sure you withheld that medication. In patients who report allergic reactions, if there is a doubt, we can do a skin test for these patients. A couple of other concerns for us. Patients who are taking penicillin may get a gastrointestinal upset when they take it by mouth. We need to be sure that the oral forms are given on an empty stomach. So that means that we give it usually an hour before or 2 or 3 hours after a meal. And you might have a question about another drug called probenecid, which when given with penicillin increases the blood levels of penicillin. So you might see that being given with penicillin. The next category is fairly closely related to penicillins. These are the cephalosporins. The category of cephalosporins is closely related to penicillin. These drugs are known by their ceph-kef in their names. So you see a drug like cephalexin, which is Keflex, or cefazolin, which is Ancef. You're going to see either ceph or kef usually in the names of these. There are 4 generations of the cephalosporins. For your NCLEX exam, I don't think you have to know the exact differences among those. Just remember that they do have some different organisms that they are appropriate for, so that you can't just totally interchange the cephalosporins. While we call them closely related to the penicillins, one of the things that makes that so is that there's a cross allergy to penicillin. So about 20-25% of people that are allergic to one will also be allergic to the other. So that tells you something about your important nursing care in terms of assessing whether they have an allergy to penicillin when you're giving them a cephalosporin, and vice versa. Cephalosporins, as most of the antibiotics, can cause renal toxicity. Another category of the antimicrobials are the erythromycins. These tend to have the term ILO in their generic names, although not all of them have that terminology. I put erythromycins right after penicillin and cephalosporin in that erythromycins are frequently given to patients that are allergic to penicillin. So that kind of, you want to group them in your thought process. They're also very effective against conditions like Legionnaire's disease and mycoplasma infections, which are rather difficult to cure. Chlamydia, Borrelia, which is what's transmitted by the deer tick that causes Lyme disease. Haemophilus influenza, the H. pylori, all of these are responsive to erythromycins, such as Biaxin, which is one of the newer erythromycins. Erythromycins usually come in enteric-coated tablets. Acid decreases the activity of erythromycin, so we coat them so that they won't be dissolved in the stomach, but rather in the small intestine. Remember, enteric refers to the small intestine. We don't want to give these with meals or with acids, so don't give it with fruit juice, for instance, because that decreases the activity of the medication. Remember that you cannot crush, cut an enteric-coated tablet of any kind, not just erythromycin, but any type of enteric-coated tablet. If you cut it, then the acid can get to it and it will dissolve in the stomach rather than in the small intestine where it's supposed to. Now, if the erythromycins like Biaxin were being given to treat conditions such as mycoplasma, which some forms of this, of course, are, or chlamydia, your sexually transmitted diseases, remember that they will probably treat both partners, not just the one that's obviously ill. Now let's move on and talk about another category of antimicrobials, and these are the tetracyclines. Tetracyclines are used to treat rickettsial infections. These are things like Rocky Mountain spotted fever and Lyme disease. They can also treat mycoplasmas, chlamydia, acne. A few words for us about the management of patients taking tetracyclines. You can't use any milk products or any minerals like zinc or iron at the same time that you're giving tetracycline. So you don't take your vitamin mineral pill at the same time you take tetracycline. You need to space that out a few hours. People who are taking tetracyclines are very sensitive to sunlight, and this is a favorite type of question. So they need to cover themselves up when they're going out in the sunshine when they're taking tetracycline. And the other major side effect that we need to know about tetracycline is that what we call gray tooth syndrome. If tetracycline is given to women in the last trimester of pregnancy or to children under the age of about 8, we tend to see that they develop gray teeth. Now, their teeth are okay, they're just unattractive. So we usually do not give tetracyclines to children. Interestingly enough, it's the second teeth that are affected, even when the pregnant woman has it. So it's the second teeth that will be affected. We need to know that with both the penicillins and the tetracyclines, your oral contraceptives may no longer be effective when when they're taking those antibiotics. The last of these, or near the last of one of these groups that I want to talk about, is chloramphenicol or chloromycetin. As you can see, I call this the big guns drug. And I've got these big tanks pictured here for you to remind you that it is the big guns. We don't give it very often because of its severe toxicity, which is aplastic anemia. So we can kill the infection, but you'll put the patient into bone marrow depression. This is used in cases where other antimicrobials are ineffective. So we can use it in Haemophilus influenza meningitis if it's not responding to the other drugs. Typhoid fever, Rocky Mountain spotted fever that doesn't respond to the tetracyclines, for instance. But it is very toxic. We said aplastic anemia. So you'll see that being given only in severely ill people who do not respond to other medications. We need to mention the category of drugs known as quinolones. Notice their key ending is oxycin. So this is norfloxacin, which is noroxin, or ciprofloxacin, which is Cipro. These drugs can be used to treat lots of gram-negative bacteria and some gram-positive, so things like Pseudomonas, and also some of your genitourinary infections respond to the quinolones. We know that you can get GI disturbances as a side effect, as we can with almost any drug, if you note. Food delays absorption, so we give this on an empty stomach with a full glass of water, and we also recommend that they don't take a lot of milk and yogurt because that decreases the absorption of Cipro. We want to move on into another category of antimicrobials called the sulfonamides. Now the key endings for this, or beginnings if you will, are sulfa and gant. A lot of them have terms like gantracin, gantanol in their trade name. And they all have sulfa somewhere in their generic name. These include things like sulfasalazole, gantracin, Bactrim, sulfasalazine, which is a sulfidine, or Septra. So these are some of the drugs that we see in the sulfonamide family, used for a lot of UTIs and also for things like ulcerative colitis and Crohn's disease. You may see that used as a bowel prep prior to bowel surgery. Adverse reactions include one of the same things that we saw with the tetracyclines. We see the sensitivity to sunlight. It can also cause renal stones, so the patient who's taking sulfa drugs needs to drink lots of fluids so that they aren't going to get kidney stones. And we can cause GI upsets as well as that photosensitivity. I think the photosensitivity and the kidney stones are what they're most likely to ask you questions about. Then there are a whole group of urinary tract anti-infective agents. And these are drugs that are not well absorbed systemically. These are drugs that are used directly to kill bacteria in the urinary tract. So things like mendelamine, or nalidixic acid, which is Negram, or nitrofurandantin, which is macrodantin. Now, we need to remember a few things about this. Certainly we want our culture before, so we need to get the clean cuts before and after treatment to make sure that it's been effective. And we need acid urine for these drugs to be effective. So this means have them take cranberry juice or sorbic acid so that we keep a very low urinary pH. You might want to monitor intake and output, and just to be sure that they're having plenty of fluids. And we want to look at anti-tubercular drugs. Anti-tubercular drugs are important ones that you may well see. Most patients are getting 2 to 4 drugs, and they're given over a period of months, sometimes for as long as a year to 2 years. INH, or isoniazid, is the mainstay of the anti-tubercular drugs, used both to treat active TB and also to treat people who are positive skin test and negative X-ray. The major toxicities are liver toxicity and peripheral neuritis. To monitor liver toxicity, we do liver function tests, particularly the AST, used to be SGOT, and monitor that baseline and then during therapy. And to prevent peripheral neuritis, we need to give this with vitamin B6. Other drugs that might be used might include streptomycin, which we've already talked about, PAS, para-aminosalicylate sodium. This always sounds to me like aspirin, salicylate, so it reminds me it has GI side effects. This one we give with meals. It's the only one that we give with meals. Rifampin, or Remactane, has as its major side effect, it turns body fluids red, or sometimes we describe it as orange red. Remember that this, like many antibiotics, affects the action of other drugs. And certainly affects things like oral contraceptives and steroids and many drugs. Ethambutol is a medication that is used to treat TB, and it can cause optic neuritis, it can cause red-green color blindness, can also cause gout. So the drugs that are used to treat TB are drugs that are certainly quite toxic. But since we are seeing a recurrence of tuberculosis in this country, I think you need to be well aware of these kind of drugs. There are often questions about those on NCLEX. The next category of drugs that we want to look at are the antiviral agents. Viruses are very difficult to treat because they don't have cell walls, and most antibiotics interfere with cell wall synthesis. Perhaps the better way to deal with viral conditions is immunizations to prevent them. But we are making progress in treating viruses. One that we have the best progress in is in treating things like herpes zoster and herpes simplex 1 and 2. And acyclovir, Zovirax, famciclovir, Famvir, there are several in that family of agents that are used to treat these conditions. Note that they all have VIR in the name. That's a real clue to you that these are antiviral drugs. We need to remember that these drugs do not cure the illnesses and they do not prevent transmission of the illnesses. That's a very important part of the teaching for patients. When patients have herpes outbreaks, the earlier we can give the medications, the better the results are. Patients who have recurring outbreaks may be given open prescriptions so that they can take medication at the very beginning of an outbreak. The major side effects are going to be headache, and sometimes they're quite severe, and arthralgia, sometimes joint pains can occur with patients who are taking the medication. We want to look at a couple other types of antivirals. We have antivirals to treat influenza A, and these are things like amantadine and rimantadine. We simply need to look out for orthostatic hypotension and avoiding over-the-counter medications like aspirin and acetaminophen. There are some antivirals that can treat cytomegalovirus in people that are immunocompromised. So these would be folks who are on cancer chemotherapy. These are people who have HIV perhaps. Interestingly enough, one of the major side effects is bone marrow suppression along with headaches. We're beginning to see a pattern here, aren't we, with bone marrow suppression and headaches as major side effects. You can also get renal damage, so renal function tests are going to be monitored during therapy. I want to take a look at the antiretrovirals, and these are drugs that are being used to treat HIV infection. They, again, all of these drugs interfere with the replication of HIV. They do it in slightly different ways. They do not cure AIDS. A couple other things that apply to all of these categories are going to be things like they don't cure AIDS, their patient is still infectious. You need to teach the families about that and the patients about that. They should refrain from taking over-the-counter medications because there are a lot of drug interactions with these antiretroviral drugs. The first category are called the nucleoside analogs. These are drugs that are given mostly by mouth. Zidovudine can be given intravenously. These have been around perhaps the longest of these categories of antiretroviral agents. Major side effect of these is a big one, bone marrow suppression. And it may be so severe that the patient may need to take a drug called Epigen that helps to raise the red count. Don't forget the teaching related to bone marrow suppression. In other words, stay away from infections and get monitored blood counts at regular intervals. Again, they can get headaches, the same kind of pattern of things that we're seeing over and over again. The non-nucleoside analogs are another category of the antiretrovirals. Again, the same cautions, they don't cure AIDS. Notice the drugs that they have a VIR in the trade name, don't they? Delavirdine, Rescriptor, and Viramune even has one in its trade name. This particular group is almost always given with other drugs so that resistance does not develop as quickly. Protease inhibitors. Again, you've got VIRs in the names that are going to be clues to you that these are antiviral medications. And there are just a couple more small categories of medications in the antimicrobial field. Antifungals, and the big one here is amphotericin B, also sometimes known as amphoterrible, because it has such terrible side effects. It can be used to treat histoplasmosis and also other fungal infections that some of your immunocompromised patients may be getting. It's extremely toxic. You get everything from a fever to hypokalemia, azotemia, blood dyscrasias, and bone marrow depression, anaphylactic reactions. It's so toxic that we usually give Tylenol, steroids, and Benadryl to prevent or reduce the side effects. There are a couple other minor antifungals, the mycostatin, nystatin, that are used to treat yeast infection, particularly the yeast infections that women get, the vaginal yeast infections, and those can be given both orally and by suppository. That was a big group of drugs, wasn't it? Now you might want to take a few moments yourself and kind of look at the major categories and try and make some sense out of those. These are ones that you really do need to be comfortable with for the exam. Now I want to move on and talk about medications affecting the central nervous system. So as we affect the central nervous system, we'll be looking at a number of kind of drugs. The first ones we're going to start out with are the local anesthetics. And these are ones that have the name cane in their name. So they almost all have cane somewhere in the name. Canes block pain. And you may see questions relating to this in the area of regional anesthesia. So we need to know that epidural anesthetics and spinal anesthetics both use canes as their active agent. The difference is that in epidural anesthetics we do not puncture the dura, and so there's little risk of spinal headache afterwards, whereas with spinal anesthetic the dura is punctured and there's a high risk of spinal headache, so we keep the patient flat afterwards. We also need to be sure that we push fluids after spinal anesthesia, because when cerebral spinal fluid has been lost, we need to have adequate fluid intake to replace that. You may see those being used as local anesthetics in terms of like tooth work and suturing, that type of thing. Remember that when it is given with epinephrine, that epinephrine is a vasoconstrictor, and then that's going to slow the absorption, prolong the action, and decrease the amount of bleeding. I want us to move on and take a look at non-narcotic analgesics and antipyretics. And with the non-narcotics, we have three major categories. We have salicylates, we have NSAIDs, the non-steroidal anti-inflammatory agents, and we also have acetaminophen or Tylenol. You need to note that there are some differences in side effects with that, that the NSAIDs and the aspirins, the salicylates, are analgesic and antipyretic, and they also have anticoagulant and anti-inflammatory effects, whereas Tylenol does not. If we look at major side effects, we know that the major side effects include GI disturbances and bleeding for the NSAIDs and the aspirins. We often will recommend that we give it with food to reduce those side effects. All of them can affect the liver, and Tylenol has been implicated so that we now have warnings on the packages: do not give to patients with liver disease. And they also can affect the kidneys as well. We see another drug that is classified as an anti-headache medication, and this is a drug called Imitrex or sumatriptan. And some people classify it as a migraine or an anti-migraine agent. I think the key thing that we need to know about that is that you need to avoid tyramine foods, as these can sometimes bring on the headache. We want to move now and talk about narcotic analgesics. Narcotic analgesics alter the perception of and the response to pain. We need to use narcotic analgesics when patients have severe pain, and you also may see it being used as a pre-op medication. You need to remember that narcotic analgesics are not interchangeable, that you cannot substitute one drug for another. You need to note, as you can see in the transparency here, that Tylenol number 3 contains Tylenol along with 30 milligrams of codeine. Each one of those doubles the one before it, so Tylenol number 4 is 60 milligrams of codeine. That's just an interesting fact for you to know. As far as how the narcotic analgesics work, they alter the perception of and the response to pain. They're central nervous system agents, and their adverse reactions include effects on the central nervous system. The biggie one that they love to ask questions about is decreasing respiratory effort, particularly in patients who are taking morphine. We may also see a decrease in alertness levels, so they could ask you questions about things like safety things, side rails, for instance. You've got to monitor vital signs because blood pressure and pulse will be decreased. It also suppresses cough reflex, slows peristalsis. That may indeed cause vomiting. We don't give narcotics to patients with head injuries because it can raise intracranial pressure. They can also cause urinary retention. In addition, as if that's not enough, they also are addictive, and they will potentiate any other central nervous system drug. So be sure you include that in your teaching. For instance, if a patient is to be discharged, they shouldn't go home and start self-medicating their misery with alcohol and continue to take their narcotic. That's a potentially fatal combination of medications. A couple more comments about narcotics. Narcotics will cross the placenta. So it's very important when we're giving this to women who are laboring, for instance, that we give it at least 2 hours before delivery, so that we don't have a sleepy baby as well. You might be asked to check the pupils because narcotics will cause the pupils to constrict. When we're talking about narcotics, we need to mention narcotic antagonists, and Narcan, don't you love the name, narcotic antagonist, is used to treat opiate-induced respiratory depression and narcotic overdose. Remember that it competes for and wins. It actually blocks the opiate receptors in the brain, so that if the patient is an addict, they will go into immediate withdrawal symptoms when you give them Narcan. You need to remember that it's quick-acting, will save lives very quickly, but it's also short-acting. So you need to continue to monitor respirations, and sometimes they need a second dose of Narcan until the narcotic has worn off. We want to move on now and look at the area of drugs called sedatives and hypnotics. These are also central nervous system drugs. They interfere with nerve impulses in various parts of the brain. So we can use it for anything, to induce sedation, to treat insomnia, and induce sleep before surgery, for instance. We have several major categories. The barbiturates. These are easy to recognize because they all end in the term barbital. Phenobarbital, secabarbital, amibarbital. They're all barbiturates. These are used both as sedative agents and also as anticonvulsants. These cross the placenta and are also found in breast milk, so are not appropriate to give to pregnant or lactating women. Benzodiazepines are a huge group of drugs. These are ones that include Valium, Xanax, Versed, Cirax, Ativan, Halcyon, Librium, all in this major kind of category called benzodiazepines. And the non-benzodiazepines are almost everything else that are in that sedative hypnotic area that don't fit into those two categories. Remember, in terms of the major side effects for all of the drugs in these categories, they cause drowsiness, central nervous system depressant. They have addiction and cross-addiction with other drugs that are central nervous system drugs. So an alcoholic will become much more quickly addicted to one of these drugs. And they also all have the potential to decrease respirations, and that's something that we need to be very much aware of when patients are taking these. We want to talk also about anticonvulsants. And anticonvulsants help to control seizures by reducing seizure activity in the brain or else preventing the spread of the seizure focus. We have several categories of anticonvulsants. Hydantoins is one of the major categories. That one's been around for a very long time. We also have, that's Dilantin, by the way. And you need to know the major side effect for Dilantin, hyperplasia of the gums. And we need to check both CBC and kidney and liver function because it can affect all of those. And remember to teach patients that alcohol reduces the effectiveness of Dilantin. Other categories of anticonvulsant drugs that we see are the Valium, the benzodiazepines. So this is Valium. Carbamazepine, which is Tegretol. And then, of course, the barbiturates. And we just talked actually about those categories of drugs. Now, you want to remember that all of these are central nervous system depressants. One thing that they might ask you about Dilantin, we need to monitor serum Dilantin levels. The therapeutic level is about 10 to 20 micrograms per milliliter. 10 to 20 micrograms per milliliter. We want to teach patients that they should never abruptly stop taking anticonvulsants. And we need to remember also that you do not mix Dilantin with dextrose when it's to be given parenterally. It must always be mixed with saline. And that would make a really neat examination question. Mix it with saline, never dextrose. Also included in the central nervous system category are drugs like skeletal muscle relaxants. These are drugs like baclofen and soma and dantrolene. These have the traditional central nervous system side effects, including drowsiness. And you need to know that these are often combined with analgesics, sometimes narcotic analgesics, so you may have those type of side effects to deal with as well. Another whole major category of central nervous system drugs are the anti-Parkinsonian drugs. And these are drugs that hopefully balance the neurotransmitters. With Parkinson's disease, there's thought that there's not enough dopamine and too much acetylcholine. So treatment consists of giving dopamine and blocking acetylcholine. So if we look, we can see that the anticholinergic drugs that will be given are drugs like cogentin and artane. Now remember that these are contraindicated, however, in people with glaucoma or BPH, which is sometimes difficult because those are very common conditions in this age group of patients. To combat the decrease in dopamine, we give drugs that will increase dopamine. And these are drugs that usually have dopa in the name. So these are going to be drugs like carbidopa, levodopa, these type of medications. And that's a dead giveaway, isn't it, with the dopa in it. Amantadine is another one. We saw that earlier being used as an antiviral. But amantadine or Simitril helps to release dopamine. Parladel is another one that can be given because this increases the amount of dopamine in the brain. We want to look at antipsychotic agents. And when we talk about antipsychotic agents, these are drugs used to treat psychiatric disorders. Now they all have in common certain types of side effects. So we can expect that all of our antipsychotic agents are going to have anticholinergic side effects. We sometimes talk about red as a beet, hot as a hare, blind as a bat, dry as a bone, mad as a hatter, reference to Alice in Wonderland. But in other words, they get vasodilation, tachycardia, mydriatic, pupil dilating effects, dry secretions, and sometimes nervousness and disorientation. They can all have the possibility of causing cardiovascular effects, dysrhythmia, and postural hypertension, as well as liver, blood, renal effects, and central nervous system depression. So they're all going to have anticholinergic, all going to have central nervous system depression. It's amazing. Every drug we give has many, many side effects, doesn't it? Now, with the first category of drugs that we wanted to talk about, we want to talk about the phenothiazines. Phenothiazines block dopamine receptors. So if they block dopamine receptors, one of their major side effects is going to be Parkinson's disease, and indeed we get Parkinsonian types of symptoms. Phenothiazines are sometimes used in addition to antipsychotic agents. They're used also as antiemetic agents. All of your phenothiazines have the word zine in their name, like thorazine, even flufenazine, which is Prolixin. But in one, either generic or trade name, they have the term zine in the name. Now, when we talk about phenothiazine toxicity, we will usually give the patients drugs like cogentin or artane, the anticholinergic agents, to treat the toxicity to phenothiazines. And they quite often ask on the exam about giving cogentin or artane to your schizophrenic patient who's starting to have Parkinsonian symptoms. There are a couple of other antipsychotic agents that aren't technically phenothiazines, but actually have very similar side effects. And these are Haldol, which is haloperidol, generic name, trade name Haldol. Sometimes I remember that Haldol to treat hallucination, and that helps me to remember that it's used to treat psychoses. It's also effective in Tourette's syndrome. Clozapine or Clozaril is being used in the treatment of schizophrenic patients who don't respond or can't tolerate other agents. And the side effects are essentially the same as those that we talked about with the phenothiazines. We want to move on now also and talk about lithium. Lithium is used in the treatment of bipolar disorders, sometimes called manic depressive illnesses. It helps to even out the highs and lows that we see in those bipolar conditions. Lithium, if you look at the drugs, they all have the term lith in them. So it's like Escalith is a trade name for lithium carbonate, or lithium citrate is Sibylith. So they're real easy to identify in terms of their giveaway term, if you will. It's going to be very important for you to know therapeutic levels of lithium. The therapeutic levels are somewhere between about 0.4 or 5 up to 1.5 or 6 milliequivalents per liter. Now you'll see slight variations from institution to institution in what is acceptable as therapeutic levels. What we all agree on is that toxic level above 1.5, you get its toxicity, and by the time you get to 2, you get really severe toxicity. So we generally are going to withhold medication, or at least notify the physician, with levels above about 1.5, 1.6. A couple other things that are concerned about it. Those side effects that we need to look for that would be signs of toxicity can range from simple problems with central nervous system, where they might be having gait disturbances and drowsiness or confusion, to GI symptoms with nausea and diarrhea, to muscle rigidity, ataxia, and sometimes cardiac arrest when we get to the high levels. So it has severe toxicity. Initially, patients will be getting the levels drawn every day or two. Once they are adjusted and we get adjusted to the therapeutic levels, you'll be finding it drawn every few weeks for patients who are quite stable. We need to give this medication with meals. We need to make sure that the patient doesn't alter their sodium intake. It's excreted from the body as a sodium salt. So we need to be sure they have adequate amounts of salt. These people do not go on low sodium diets. And they need plenty of fluid so that they can excrete the lithium from the body as well. There have been questions on NCLEX about the need for salt and fluid in patients who are taking lithium. We want to move on to some more drugs in the psychiatric system, and these would be antidepressants. When we talk about antidepressants, there are several major categories. We have the tricyclics, and these are essentially the ipramines and the triptylines. So amitriptyline, which is Elavil. I love that. We know it's a mood elevator. Elavil elevates the mood. Tofranil, which is imipramine. So they really all are ipramines and triptylines in terms of their generic names. Similar to these are the atypical antidepressants, sometimes called SSRI, selective serotonin reuptake inhibitors. These are perhaps even more common than the tricyclics, the Prozac, Paxil, Zoloft medications. They have very similar side effects. For both of these categories, it takes 2 to 4 weeks to reach therapeutic levels. I often say tricyclics, try weeks, meaning that it takes that amount of time for these drugs to work. Adverse effects are central nervous system effects. So we get all that central nervous sedation. We get anticholinergic that we talked about being typical of your psych medications, and to some extent you can get some of the extrapyramidal, some of the Parkinsonian type symptoms. Postural hypotension is something that can occur with virtually all of your psych medications. Now we move on to a big category of antidepressants. I say big in terms of big side effects, and that's the MAOIs, the monoamine oxidase inhibitor. These are drugs like Nardil and Parnate. These medications are not used as often, but the side effects are very serious. These are used when patients are not responsive to any of the other antidepressants. First off, they have to go on a holiday, so they have to be off from the other drugs for 2 or 3 weeks before these can be given. And the biggie one that we see with this is the fact that you can get hypertensive crisis in patients who take any foods that contain tyramine or tryptophan. So this is essentially aged food. So we don't send these people to wine and cheese parties. They can't drink the wine, they can't eat the cheese. So they can't have anything that's aged. They can't have yogurt, raisins, caffeine, chocolate, soy sauce, coffee, anything with banana peels even, for instance, are bad for these patients. Chicken livers, avocados, so many foods that will precipitate a hypertensive crisis, that these are really very difficult for patients to live with. It can also cause liver damage as well. Now, they shouldn't take any drug that affects the central nervous system, so that means no over-the-counter cough and cold medications, for instance. There are many, many drug interactions in patients taking their Nardil or Parnate or this Aldapril, which is probably the newest one of this group. And the last of the things that we want to mention in the nervous system really relate to the autonomic nervous system. And just as a quick review of the autonomic nervous system, you want to look at the difference between the sympathetic and the parasympathetic system. Remember that sympathetic system is also called adrenergic because the neurotransmitter is adrenaline. And the sympathetic nervous system is the emergency system. It's the fight and flight system that increases the heart rate, increases the blood pressure, causes peripheral vasoconstriction to raise the blood pressure, and dilates the bronchi and the pupil. Whereas the parasympathetic, called the cholinergic system, is more of the maintenance system. It's called cholinergic because the neurotransmitter is acetylcholine. You can remember it because it promotes colon function, it promotes GI tract function, and it slows the heart rate and lowers the blood pressure. Now, as we talk about these drugs, we're going to be using the term adrenergic, adrenergic blocker, cholinergic, and anticholinergic. So you probably want to be sure that you're comfortable with the basic adrenergic, cholinergic, and then we'll get into the antis with that. The first of these that we want to look at are some of the adrenergic medications. We can use adrenergic drugs to treat shock. Things like dopamine and epinephrine and aramine and Levophed are drugs that will actually raise the blood pressure and do very well at raising the blood pressure. We may also see used in the treatment of bronchospasm. So this would be isopril and alapent and any of the theophylline-related drugs, things like theophylline and breathine, for instance. Now, all of these drugs have as side effects hypertension, and they can also cause urinary retention, tachycardia, big-time tachycardia, and nausea and vomiting because they slow down the GI tract. If we look at the flip side of that, we talk about adrenergic blockers. And these are ones that are going to lower blood pressure, and they can also be used to lower intraocular pressure. So we see a number of drugs, the whole beta blocker system being used as antihypertensives. And you may even see a drug like ergotamine being used to treat migraine headaches. Temoptic is technically an adrenergic blocker, and that's used to treat glaucoma. Now, let's talk about the cholinergic system. Cholinergic drugs are ones that produce those parasympathetic effects on the body. So a cholinergic drug is going to increase the digestive types of function. We can use cholinergic drugs in the treatment of things like abdominal distension. If you get post-op and the GI tract isn't, peristalsis hasn't returned very well, uracil could be used. It can also be used to treat urinary retention. We also see cholinergic drugs used in the treatment of myasthenia gravis. In myasthenia gravis, the problem is they don't have enough acetylcholine. So we give them a drug like prostigmine. Prostigmine and tensilon, for instance, are both cholinergic agents. Now, cholinergic agents can induce cholinergic crisis, which means that you get too much of that type of function. So you get nausea and vomiting and salivation and diarrhea, sweating, meiosis, the pupil constricts, temperature may go down, hypothermia. And the antidote for that is going to be atropine, which is an anti-cholinergic. And if we look at the anti-cholinergics, we said the number one of these is atropine. But other drugs in that category would include scopolamine, robenol, for instance. And we've already mentioned two, cogentin and artane, that are used to treat Parkinson's disease and the Parkinsonian side effects that we saw with the antipsychotic medications. Now, we can use the anticholinergics preoperatively to dry up secretions, we said in the treatment of Parkinson's. They're also used as antiarrhythmic medications. We need to know that contraindications can be glaucoma, because this is going to dilate pupils. An unstable heart rate may be a contraindication because you're going to get some increase in heart rate. We said it was used as an antiarrhythmic when you've got too slow a beat. But if you've got rapid heartbeat problems, you're not going to give anticholinergics. And the side effects are those that we mentioned a bit ago, the red hot, dry, mad, blind side effects. So that we have the flushing, the heat, the dry secretions, the confusion, and the dilated pupils that cause sensitivity to light. And one last drug in the central nervous system category that we really need to mention, and that's Ritalin. Ritalin is a drug that is used to treat attention deficit disorders. Couple things that we need to know about Ritalin. Ritalin should not be given in the afternoon or evening because you don't want to keep this person stimulated. So it's usually given in the morning before the child goes to school. Ritalin tends to suppress weight gain. It tends to cause tachycardia, and it's very possible that the patient could get seizures, or another side effect could even be an occasional psychotic episode. So while Ritalin is very frequently prescribed for attention deficit, it's not without side effects and really needs to be monitored very carefully by the physician. Our next topic for discussion is drugs that affect the heart and circulatory system. The first of these groups that we're going to look at are the cardiac glycosides. This is the digitalis family of medications. We know that these are plant alkaloids, that they act directly on the cardiac muscle and they improve myocardial contraction. They act on the SA node, the AV node, and the ultimate result is that the heartbeat is slowed and strengthened. This results in increased blood supply to all of the organs. There are a few things that we need to know about when we are thinking about giving cardiac glycosides. They start with a loading dose, and this means that the patient gets a higher than normal dose to quickly bring the levels up to therapeutic levels. Once they've reached therapeutic levels, then the maintenance dose is a much shorter dose. Now, cardiac glycosides are long-acting. They really are acting fairly strongly for at least a week, and they stay in the body for up to 2 to 3 weeks. This is one of the reasons that there's such emphasis on nurses being able to pick up toxicity to digitalis. And this is something that they're likely to ask you about. Toxicity includes things like bradycardia. Remember, in an adult, if the pulse rate goes below 60, you would withhold the medication and notify the physician. In an infant, this rate would be 100, and a toddler about 90. Other signs of toxicity would include dysrhythmias. Sometimes patients will get a bigeminy, a double beat. So in an adult, if the heart rate goes above 100, you probably would want to report that as well. Other problems are associated with the GI tract: anorexia, nausea, vomiting. So if your patient develops these symptoms, these should be reported. And sometimes disturbances with green and yellow vision. Now, it says on your picture here to check the potassium level. DIG doesn't directly affect the potassium level. However, in the presence of a low serum potassium, you're going to get digoxin toxicity much more quickly. And usually when we give DIG, the patient is also getting Lasix, which is a potassium-depleting diuretic. So it's really important to keep a good handle on those potassium levels. You need to know the serum digoxin levels, and this is something you absolutely, positively have to know. Therapeutic levels are somewhere between around 0.8 to 2.0 nanograms per milliliter. Once we get above 2, you need to hold the medication and notify the physician. And when you get about 2.5, potentially fatal toxicities occur. There are likely to be questions where you monitor someone's serum DIG level, the lab report comes back, and it's 2.0. What do you do? Well, let's make it 2.1 where it's rather clear for us. So the serum DIG level is 2.1. The answer is you're going to hold the DIG and notify the physician. Do not administer that dose. That dose is going to stay in the body if you give it for 1 to 3 weeks. So be sure when in doubt, check with the physician about DIG toxicity. If patients are also getting drugs like anticholinergics, like erythromycin, tetracyclines, verapamil, which is a calcium antagonist, it increases the serum DIG levels, so they're at higher risk for toxicity. Digoxin is not absorbed by fat. So obese people don't get higher dosages than skinny people. And one other thing we need to know about DIG is that there is an antidote. And the antidote is called digoxin immune FAB, which is sometimes called Digibind. And if there are life-threatening DIG toxicities, Digibind can be used to help reduce the effects of the digoxin. Other drugs in the cardiovascular system are the anti-anginal drugs. And these are really coronary vasodilators. Because they dilate the coronary vessels, they're going to reduce the pain that we see in angina. And the good old standby for these are the nitrites and the nitrates. These are another category of drugs that are absolute must-knows for you in terms of the licensure exam. These drugs decrease the myocardial oxygen needs, and they dilate the large coronary vessels. They're easy to identify because they've all got nitro somewhere in their name, so you're not going to have a hard time identifying nitrates. There are a few thoughts that we need to keep in mind about the nitrates. Nitrates come in a number of forms. They can come in oral forms, they can come in sustained release oral tablets, they can come in sublingual, they come in paste, they come in patches, so it comes in a number of different ways. Traditionally, almost every patient who has angina is likely to have a prescription for sublingual nitroglycerin. Now this goes under the tongue. It's not chewed. It's absorbed directly into the bloodstream from under the tongue. It's given at 5-minute intervals times 3 doses, and this is something you should remember. It's stored in a dark glass container in a cool place because it's very sensitive to light and heat. It's also sensitive to humidity, so the refrigerator is not a good place. It has a short shelf life, about 3 to 6 months maximum in terms of your shelf life. We need to remember that if you're giving it in the paste format, you need to measure the paste very carefully, and that's usually measured onto a little tape-like in inches. Then when you apply it to a relatively hairless area of the chest, you may cover that with a plastic wrap and tape that in place. When you put on a new dose, of course, be sure to remove the previous dose so that you're not double dosing patients. Wash off the previous area. The same thing goes with patches. When you're applying a new patch, be sure that you remove the previous patches. The major side effects are related to the vasodilating effects of the nitrates. So they dilate the coronary vessels, but they also dilate cerebral vessels. And when they dilate cerebral vessels, this is going to cause headache. When they dilate peripheral vessels, this can cause hypotension. It's important to note also that tolerance develops, so that as patients take nitroglycerin, they may get less and less effect from it, or need more and more medication to get the same vasodilating effect. Another group of drugs also used to treat angina are the calcium channel blockers. These reduce oxygen demand by inhibiting the influx of calcium through the muscle cell. Examples of those drugs are drugs like Procardia, which is nifedipine, and verapamil. Now notice one of the trade names for verapamil is Calan, C-A-L-A-N, calcium antagonist. Once again, the name is really clear for us. For that matter, Procardia, you know, is a heart drug, don't you? So get all those clues you can from the names of drugs. We said that the calcium blocking agents are used to treat angina and those supraventricular type arrhythmias. They end up decreasing the myocardial need for oxygen. The side effects are real similar to those that we talked about with the nitrates: hypotension, headache. In addition, we can see changes in pulse rate. As a general rule, with any drug affecting the heart, if you were asked about what would you assess, you're going to assess heart rate, rhythm, and blood pressure. So heart rate, rhythm, and blood pressure you should always check. There are some peripheral vasodilators, rather than simply the coronary artery ones, peripheral vasodilators, and these are oftentimes used in the treatment of peripheral vascular disease. These would be drugs like vasodilin, vasospan. Now those, you know, affect blood vessels, don't you, with the word vaso in the name. If these are vasodilators, one would expect that side effects would include things like vasodilation, like flushing, for instance, and that indeed we may see with those drugs. We want to look also at antiarrhythmics, and these drugs help to correct rhythm problems with the heart. They try to bring the heart back to normal rate, normal rhythm, to make it so that the sinus node is what's controlling the heart rate. As we look at this whole group of drugs used to treat ventricular dysrhythmias, we can make some generalizations, and let me make them for you. Essentially, all of the drugs except beryllium are well absorbed from the GI tract and are given by mouth. Most of them can also be given IM or IV. Since they're all designed to essentially slow the heart rate, they're used to treat ventricular tachys and fibs, so they're supposed to slow the heart rate. You need to watch for bradycardia as a side effect. You might even have some other dysrhythmias popping up. Now, if we look at these slowing down type drugs, we can start with a drug like quinidine, and that decreases the excitability of the heart, used to treat AFib, atrial fibrillation, and some ventricular dysrhythmias. Yes, it's the same drug that's used to treat malaria. That has some anticholinergic effects as well. And you can have some side effects that would include, in addition to the potential heart problems, effects that might even cause hearing problems and blood dyscrasias. Another drug like Norpace, again the name tells you it's going to pace the heart, can sometimes cause heart block, so that this is another one of those, if the pulse goes below 60, you'd want to hold the drug and notify the physician. The next of the drugs we want to look at is lidocaine or xylocaine, and this is one that I often call the granddaddy of drugs. This is used to treat the ventricular dysrhythmias, not for atrial, simply for ventricular dysrhythmias. It's usually given IV bolus and then followed by an IV drip. Oftentimes you'll see it given for patients who've had an MI and are developing those potentially fatal PVCs and the tachycardia. Some of the adverse effects, in addition to the things that we talked about earlier being the potential rhythm disturbances, we can see a general kind of central nervous system depression or stupor. Oftentimes they are much less alert when you're giving them lidocaine. You may also see a respiratory depression, so that's something you need to be alert for in patients receiving lidocaine. Another one of the drugs is Dilantin, phenytoin sodium. We think of that often as an anti-seizure medication, and it is. But remember that seizures are abnormal electrical impulses in the brain, and a cardiac dysrhythmia is an abnormal electrical impulse in the heart rate. And additional side effects that we might see by this could be even ataxia, or sometimes nystagmus, where the eyes kind of move back and forth. The overgrowth of the gums is a major one. When this is given intravenously, we give it in a slow IV push. Otherwise, there is some possibility of vascular collapse resulting from this. Remember that when you are giving Dilantin, you never mix it with dextrose. You'll get crystallization occurring. So you need to flush a line with IV saline before you are giving it and after you give it. Never dextrose with Dilantin. Another one of the drugs to look at is procainamide or Pronesto. Procainamide sounds like lidocaine, and again it's used to treat the dysrhythmias. side effects occur the same general kind that we were talking about. Severe hypotension can occur. You usually, if you're giving this IV, you keep the patient supine. Otherwise, you're going to see even more hypotension. And as most of these drugs, you can get bradycardia with that. Sometimes your patients will complain about a bitter taste when they're taking Pronestil. Pronestil can be given both IV and in the long haul can be given as an oral preparation. Bertilium, and remember this is the one that can only be given intravenously, and it's used for VFib, not for atrial dysrhythmias. And the side effects are again the same ones that we're talking about. Orthostatic hypotension. Another one we might want to mention, adenoside or adenocard, again used for ventricular dysrhythmias, can also be used in the treatment of supraventricular tachycardia. So it slows impulse formation in the SA node and slows conduction time. Same action, monitor blood pressure, pulse, and the rhythm itself. And the last of these that we want to look at is the cardarone, amiodarone or cardarone. Again, this is used in the treatment of ventricular dysrhythmias only, decreases AV conduction. If the patient's pulse is less than 60, if the blood pressure systolic is less than 90, you're going to withhold this medication. So if we were to summarize the nursing care, or particularly the observation for side effects, we'd say watch for bradycardia, give it equal intervals, and monitor blood pressure as well as pulse rate. You might want to have the antidotes, actually they aren't technically antidotes, but drugs to combat a slow heart rate, drugs like isopril and atropine, available when administering these medications. We want to move now and talk about beta blockers. These are beta adrenergic blockers. And when we talked about the nervous system medications, we mentioned these, but we didn't talk about them in detail because these are used usually in the treatment of hypertension and cardiac dysrhythmias. Note that the beta blockers all have a wall in either their generic or their trade name. So Inderal has been around one of the longest times, but the others have a lull in the generic name. Tenormin is a real common trade name for atenolol with this. If we look at what it does, they block the adrenergic or adrenaline, the sympathetic nervous system fibers, the beta fibers of the adrenergic system. So what it's going to do is slow the heart rate, lower the blood pressure. And side effects are going to be related to that. They're going to be severe bradycardia. In addition, we see a couple other side effects. We can see an increase in airway resistance, which translates to mean that you probably don't want to give this to an asthmatic patient who already has too much airway resistance. You can also see effects on blood sugar as well in patients who are taking beta blockers. What would you monitor on a patient taking a beta blocker? First and foremost is blood pressure. Monitor it to make sure it's effective and monitor it to make sure it's not going down too low as in terms of an adverse side effect. And the last category of the rhythm-related drugs that we want to talk about are the cardiac stimulants. These are essentially drugs that are autonomic nervous system drugs and increase the heart rate. We talked about drugs like isopril a few moments ago when we talked about the central nervous system drugs. These act directly as cardiac stimulants and increase the heart rate and raise the blood pressure. And atropine is actually an anticholinergic drug that blocks the vagal stimulation. So it blocks the brake, if you will, on the heart rate. And the ultimate result then is that it increases the heart rate. It causes as side effects, of course, dry mouth and blurred vision, and sometimes also dilated pupils. We want to move on now and talk about anticoagulant medications. These are given to patients at risk for developing clots. They're also given to prevent clots from enlarging or from fragmenting, really breaking up. Anticoagulants do not dissolve clots. Anticoagulants do not dissolve clots. That would be an important fact to remember, one that's probably going to show up in a question somewhere along the way. People that get anticoagulants are folks with pulmonary emboli, MIs, strokes, deep vein thrombosis are probably the main indications. We're going to start with heparin and then move on to Coumadin. Heparin blocks the conversion of prothrombin to thrombin and therefore prolongs the clotting time. Heparin has to be given parenterally, either IV or sub-Q, because it's destroyed by the gastric juices. So that means if you took it by mouth, it would have no effect. The antidote for heparin is protamine sulfate, another must-know piece of information. And diagnostic tests used to monitor the effectiveness of heparin are PTT and APTT, activated partial thromboplastin time. Generally speaking, when the patient is on anticoagulants, we want the PTT or APTT to be about 1.5 to 2 times the control values, which are the normal values. Sometimes these are expressed in INRs, International Normalized Ratio. Usually, again, we want them around 2. You may also be monitoring platelets in patients who are taking heparin. Another anticoagulant is warfarin, things in the warfarin family, and this is Coumadin dicumarol. This is oral medication, and usually when the patient is started on heparin, then before discharge they're likely to be converted into taking Coumadin. Coumadin acts differently. It blocks prothrombin synthesis, or it blocks the production of prothrombin. As we said, it is given by mouth. Thou shalt know that the antidote for Coumadin is vitamin K. So remember, K, Coumadin, and that's the antidote. The diagnostic test to monitor the effectiveness is PT, prothrombin time, and we want it about 1.5 to 2 times the control or normal value. It may be reported in INR, and usually therapeutic levels are again around 2. Remember that there are many, many drug interactions with Coumadin. Patients should be warned to take no drugs that aren't prescribed for them and to let their physician know they're taking Coumadin. Patients should not take any non-prescribed aspirin, for instance, because it will potentiate Coumadin. They also should not take drugs like phenobarbital because it interferes with the action of Coumadin. A lot of patient teaching needed in patients who are taking Coumadin. There are also some antiplatelet drugs, drugs like Riopro and Persantine, that actually prevent platelet aggregation and decrease clotting. If you were asked about a major side effect of an antiplatelet drug, you would probably tell me bleeding, and you would be correct. If a patient is taking antiplatelet drugs, and for that matter, if they're taking Coumadin, we want to avoid large amounts of vitamin K foods, because remember, vitamin K is a clotting factor, and it's the antidote for Coumadin. You want to avoid salicylates on any of these anticoagulants. And remember that anticoagulants should be discontinued 2 weeks prior to surgery. We also need to look at another category of drugs used for some of the same problems, and these are the thrombolytic drugs. Thrombolytic drugs actually dissolve clots. So these are used in the immediate treatment of an MI, a stroke, pulmonary embolus, any kind of clot that has immediately happened. Drugs in this category include TPA or alteplase, that technically is tissue plasminogen activator recombinant. TPA or alteplase is an awful lot easier to say, isn't it? Streptokinase and urokinase are cheaper drugs that are in the same family. I say cheaper, they're only a couple $100 a dose, whereas TPA is $1,000 to $2,000 a dose. These drugs actually dissolve clots. Now clearly the major side effect is going to be bleeding if they're dissolving clots. Now when these are given to treat an MI, we have to give it within 6 hours of the infarct or it's not effective. When it's given to treat a stroke, a cerebrovascular accident, it needs to be given within 2 hours of the episode in order to be effective. Other drugs in the cardiovascular system that we want to take a look at are the anti-lipemic agents. And anti-lipemic agents are drugs that are used to treat atherosclerosis by lowering the blood cholesterol. And they also tend to lower triglycerides and the LDLs, the lousy ones, the low density lipids. So if we take a look at some of the drugs, I want us to look at cholestyramine or Questran. Now somehow that's a fatty sound, isn't it? Like you think of the gallbladder and cholecystitis. It's just a rather fatty sounding name, I think. Essentially what cholestyramine does is it binds the bile acids in the intestine and it causes increased fecal excretion, which causes increased production of the bile acids from cholesterol. In other words, it tends to prevent the absorption of the fats, and it also tends to lower LDL cholesterol. Remember that cholestyramine looks kind of like Metamucil. It's granules that you mix in liquid, and you need to take that, of course, at mealtime if it's acting in the GI tract. Other drugs that we might take a look at are going to be drugs like gemfibrozil, which is Lopid. This inhibits the lipolysis, and it inhibits also the synthesis or the production of triglycerides. Other major category of drug are the whole statin category. Lovastatin, which is Mevacor, and Simvastatin, which is Zocor. These are technically called drugs that inhibit HMG-CoA reductase. Just remember that they're anti-lipemic agents. They not only lower LDL and triglycerides, they also raise HDL. Now they all have statin in their name, so that might be a clue for you. Now when patients are taking anti-lipemic agents, these are always done in conjunction with diet, so they need a low-fat, high-fiber diet. We don't like to take them with other medications because most of your medications are dependent upon fat solubility to be picked up, and we're affecting that when we give these drugs. The patient might need water-soluble forms of the fat-soluble vitamins, the A, D, E, and K. You need to monitor for bleeding, especially when they're taking Questran, but to some extent with all of these, because this could indicate decreased amounts of vitamin K. And certainly we follow up with monitoring cholesterol and triglyceride levels in these patients. Most of the time, patients are going to be taking these anti-lipemic agents for several weeks or months to know if they're going to be effective. This isn't something they take for a week or two and they cure their problem. It really involves a long-term commitment to it. Remember that anti-lipemics should not be taken at the same time as other medications. So we should either take them an hour before or 4 hours after anti-lipemics. So take the other medicines an hour before or 4 hours after the anti-lipemics. One more really major group of drugs that affect the cardiovascular system, and these are the antihypertensives. Antihypertensives lower blood pressure by actually causing peripheral vasodilation. Now, they all do it by different mechanisms, but essentially that's what they do, is they cause peripheral vasodilation. That means that they all have one side effect in common, orthostatic hypotension. So that's something to keep in mind that will go across all types of antihypertensives. So when you are monitoring patients who are on antihypertensives, take the blood pressure both flat, supine, and in an upright position. Teach your patients to change position slowly because they're at risk for orthostatic hypotension. Teach them things like avoiding very hot showers and baths because of the vasodilating effects. And they should also avoid alcohol intake because of its vasodilating effects. You need to teach them also that they can get a rebound hypertension if they abruptly discontinue the medication. And they may try to do that because either they're tired of it or it costs too much. But it's very important because quite so often you'll see patients who stop their blood pressure medicine, then had a stroke within a few days or weeks. Teach patients that if they get side effects, they need to report them because usually we can adjust the medication so that they don't have to live with severe side effects. And remind them that they shouldn't take over-the-counter drugs without their physician's approval because a lot of those drugs are drugs that are in fact going to raise the blood pressure. Now, if we take a look at some of the different categories of drugs, of the antihypertensives, the central acting ones are sometimes called alpha agonists. This is your catapres and aldemate. And these essentially depress the activity of the sympathetic nervous system. We might also look at the big category called ACE inhibitors, angiotensin-converting enzyme inhibitors. These prevent the conversion of angiotensin 1 to angiotensin 2. And angiotensin 2 is really a potent vasoconstrictor. So we decrease the vasoconstrictor and promote vasodilation. These are all prils. You've got captopril, enalapril, fosinapril. So they all have prils in their generic name. Trade names vary, things like Capitan and Vasotec and Monopril. So the trade names don't all give you the clue, but the generic name does. We might also have vasodilators like hydralazine or epresoline. Acts right on the smooth muscle of the blood vessels. We might see alpha adrenergic blockers, and these are the zosins, drugs like doxazocin, which is Cardora. Minipress is a very common one, prazosin. But they all have that giveaway part with the zosin in their name. Most of the, particularly these zosins, you want to give the first dose at bedtime because they're really apt to have a major drop in blood pressure. Hytrin, interestingly enough, is used not so much as an antihypertensive anymore, but it's used to treat men who have benign prostatic hypertrophy. It helps to relax the sphincter. So if you were asked about major side effects of any of the antihypertensives, you'd be looking at orthostatic hypertension as a biggie, and many of them can also have drowsiness because they affect the central nervous system. Remember, teach them never to discontinue these drugs abruptly. Another side effect that many times we see from a number of those, is impotence in men, and they have difficulty with erections. You want to remember to tell the man if this occurs to notify the physician. Don't just stop taking the medicine. Notify the physician. Sometimes it's very simple. Sometimes all they have to do is say, take your bedtime dose after any bedtime activities and not before. And that's maybe all that's necessary to make them have a happy and satisfying life. If that doesn't work, then they're going to change the drug and get an adjustment so that the patient can have a regular normal life as well as control their blood pressure. Now, patients with hypertension often need diuretics, and so diuretics are the next category that we're going to look at. Diuretics actually reduce the total volume of salt and water by increasing the urinary excretion of this. And it's used to treat hypertension, often a first-line drug in the treatment of hypertension. It's used to treat edema, fluid retention from whatever causes, often used in the management of patients with congestive heart failure, which is one of the times when we see it used a lot. Now, there are some side effects in common that we need to think about. All diuretics can cause orthostatic hypotension. So teach patients to change positions slowly. You need to monitor urinary output and weights in patients taking diuretics to see if they're effective. And you need to monitor serum electrolytes because they all have the potential to affect electrolytes. If we take a look at the chart, you'll notice that the thiazide diuretics, they all have Zide in their trade name, and most of them, they're seeing things like diuryl and hydrodiuryl as far as the trade names are concerned. And they tend to cause the loss of sodium and potassium. Note that they can also cause gout by raising uric acid levels. The Lasix or loop diuretic acts in the loop of Henle. There's been a question on NCLEX about that, and you really need to know that it inhibits the reabsorption of sodium and chloride at the proximal portion of the ascending loop of Henle, and that increases water excretion. Remember, the loop diuretic, loop of Henle. You really need to know about that. Now, it causes hypokalemia, it lowers serum sodium, can cause gout, just like the thiazides do. It can also affect a number of other electrolytes, so that you might see calcium and magnesium being affected as well. Can sometimes cause hyperglycemia. A couple other kind of drugs, diuretic drugs that we need to speak about. The osmotic diuretics, a drug like mannitol is an osmotic diuretic. Notice that this one will do some lowering of blood pressure, but the big effect on this is simply a diuretic effect. So this is used for people with head injuries, for instance, when we want to reduce intracranial pressure. Could be used in other types of edema with that. High concentrations of mannitol have a tendency to crystallize, so you need to check the ampule of mannitol and make sure that there are no undissolved crystals. If there are, simply warm the solution and it will dissolve. Remember, mannitol is really a strong sugar solution. We might also see some other diuretics used, like spironolactone. Spironolactone is a potassium-sparing diuretic, so you can see that this actually increases the amount of potassium in the bloodstream. Remember that if the patient is taking spironolactone, also known as aldactone, you want to be sure that they don't get potassium supplements. You might give potassium supplements with the other diuretics, but not with spironolactone. We usually give spironolactone with meals. We want to move on and talk about the potassium exchange resins. And this essentially is Kayexalate. Kayexalate, or sodium polystyrene sulfonate, Kayexalate is a lot easier to say and actually tells us what it does. K stands for potassium. Exalate tells you it's an exchange resin. And it exchanges sodium ions for potassium ions in the large intestine. So if you have a patient that has severe hyperkalemia, say a patient in renal failure, they might be given a Kayexalate enema. It's sometimes also given orally, but more often we're going to see it given in the enema form. And this is an enema that needs to be retained for 6 hours, so we don't expect them to excrete this. In addition to removing potassium ions, it can also affect the levels of magnesium and calcium and can cause sodium overload, because about a third of the sodium in that enema is going to end up being retained. When the serum potassium level comes down to around 4 or 5, then we tend to stop the use of these. Remember that the K-oxalate is not going to solve the underlying problem. It's simply going to help prevent that patient from going into cardiac arrest from hyperkalemia. The next category of drugs that we want to talk about are the hormonal agents. And the first of these that we'll look at are those agents used in the treatment of diabetes. And the first one of these is going to be insulin. Insulin, of course, is normally produced in the pancreas by the beta cells of the islets of Langerhans. In patients with type 1 diabetes, they are not producing adequate amounts of insulin. Insulin is usually administered subcutaneously, although regular insulin can be given intravenously. Essentially, this is replacement of what the patients are not making on their own. You really need to know the types of insulin, and you need to know especially the difference between the rapid-acting insulin and the intermediate insulin. Rapid-acting insulin is regular insulin, and it might also be humulin regular. Humulin simply means that it comes from recombinant DNA technology from human sources. Thou shalt know that regular insulin is the rapid-acting insulin, so it onsets quickly, half an hour to an hour, even quicker than that if it's given IV. Peaks in roughly 2 to 4 hours and lasts about 6 to 8. Intermediate insulin, on the other hand, doesn't start acting for around a couple of hours. Sometimes it might act slightly earlier than that, but usually around 2 hours or so before it acts. Peaks about 6 to 8 hours, sometimes even a little longer than that, but roughly 6 or 8 hours, and lasts all day. Very long-acting insulins are ones that don't even begin to work for 4 to 8 hours, peak in 14 to 20 hours, and last 30-36 hours. These are not given as often as are either regular or NPH. So I think the regular and the NPH and the intermediate are the ones that you need to be most comfortable with. We also have mixed insulins, so that we have like 70-30 combinations. So we have 70% NPH and 30% regular. What that does is give you the regular for now, the NPH for later. Remember that we can mix regular and NPH insulin, that you draw up the regular first, followed by the NPH. You can either remember the acronym RN or remember clear before cloudy, and regular is the clear. When a patient is receiving insulin, the major adverse effect that we have to look out for is hypoglycemia. And hypoglycemia can onset very, very rapidly. So we need to teach patients to be alert to the signs of hypoglycemia, which are going to include things like confusion, irritability. Sometimes they can get visual disturbances. And of course, remember that the treatment for hypoglycemia is indeed going to be to give them some sugar, something that they need. A couple other concerns about giving insulin. You might get atrophy of the subcutaneous fat tissue. So in order to prevent either the atrophy or the hypertrophy of that, we have them rotate injection sites. And injection sites can either be arm sites, abdomen sites, an inch away from the umbilicus, or in the thigh. We usually tell them to rotate sites, but within a particular area. So use the thigh sites, use the abdomen sites. Don't just keep going thigh to abdomen to thigh to abdomen, because there's different absorption rates in different sites. You might want to teach patients when they're administering insulin, remember the basic things like you want to gently rotate that rather than shaking the insulin. You can keep the insulin that's to be used immediately at room temperature. You might want to refrigerate the extra supplies with that. Insulin can also be administered via an insulin pump. And an insulin pump is a small device. It's externally worn, but it's designed to mimic normal insulin production. So there's a little syringe in this pump that has usually about 2 or 3 days supply. It's got 3 milliliters usually capacity. And then there is a catheter that is inserted into the subcutaneous area in the abdomen, and it continually puts out small amounts of insulin. There's usually a button that you can push for a bolus at mealtime, just before you eat. So it really is much more closely resembles the normal administration of insulin. Remember, cigarette smoking decreases the absorption of sub-Q insulin, so patients should not smoke at least for 30 minutes after the insulin injection. They actually shouldn't smoke at all if they have diabetes because of the dangers of smoking. Marijuana increases insulin requirements, so that might be a problem that you may see in some patients. And alcohol, usually excessive alcohol, requires a reduction in insulin requirements. Patients who are taking insulin, if they are going to do a lot of vigorous physical activity, will probably need an additional snack, otherwise they may develop hypoglycemia. We're going to do a question. An adult receives NPH insulin at 7 a.m. When is a hypoglycemic reaction most apt to develop? Mid-morning, mid-afternoon, during the evening, or during the night? Now, it's NPH insulin at 7 a.m. So we're going to look for a mid-afternoon type of hypoglycemic reaction. If this had been regular insulin, we would be looking for mid-morning. Remember that hypoglycemic reactions occur at peak action of insulin, because the job of insulin is to take glucose from the bloodstream into the cell. And when it's peaking, it's doing it at its greatest efficiency. We want to talk now about the oral hypoglycemic agents. Oral hypoglycemic agents are used primarily in type 2 diabetes. They lower blood glucose concentrations by either stimulating the secretion of insulin from the beta cells in the islets of Langerhans and the pancreas, by reducing the amount of glucose that's put out by the liver, or by enhancing the sensitivity of the cells to insulin. So they may act in different ways, and some of them may act in all of those ways. Some of the categories of oral hypoglycemics, the sulfonylurea agents are those drugs like Dimilor and diabinase and orinase, micronase, that have been around for a long time. And these are all drugs that have this sulfa type of base, so be cautious in patients with real allergic responses to sulfa medications. Notice that they have onsets and peaks and durations. Well, I don't think you need to memorize all of those for NCLEX. I think you do need to know that if a patient takes an oral agent and doesn't eat their next meal on time, they may develop the symptoms of hypoglycemia, exactly the same that we talked about with insulin, and the treatment is the same. Feed them. Another type of drug that we really need to be aware of now is this oral, what we call biguanide hypoglycemia.